Okay, hello everyone. I hope you can all see and hear me now. Okay. Yeah, welcome to the welcome to all of you, to all members of the eBay community and also external visitors to this first research seminar of the 2021 academic year. Most of you may know me. For those who don't, my name is Martijn Vlaskamp. I'm a Beate de Pinot Fellow here at eBay, and yeah, this year I'm coordinating together with members of eBay staff these research seminars. So last year it was coordinated by Leslie Ann Daniels and Charlie Rogers, but this year I have the pleasure to do this job. And first of all, thanks again to Charlie and Leslie Ann for doing such a great job last year and also helping me with the transition this year. So here in general, yeah, this for the moment we will start this year this digital format for obvious reasons. So all these seminars will be online until further notice. One reason is, of course, that there are still travel restrictions, so many participants could not come. And another reason is also that even if participants could come to Barcelona, well, there's these maximum capacity rules in the rooms, so that almost nobody could enter the room. Also for this reason, for the foreseeable future, we'll keep these seminars online, and then we'll simply see how things develop. So the moment we cannot do so much. So the structure is the same as in previous years. The speakers will first talk for about 30 to 40 minutes. And after that, the floor will be opened for questions and comments. So it would be nice if you have a question or comment, if you have a video camera, to quickly switch it on. In this case, Claire can also see who's asking the question. The seminar will be about 90 minutes. So this is everything from my side so far. So the first talk is directly about a very current topic. Claire Wenham will explain us what good IR can do for the global fight against COVID-19. And today's chair and also discussion will be Andrea Bianculi. Yeah, so I give directly the word to her, and she will take it over from here. Thank you.
Okay, so thank you, Martijn. Sorry, I'm sharing my video again. Thank you, Martijn, for the introduction. So it's very nice to start our series of eBay research seminars this year with such a timely topic, which is the paper that Claire will be presenting today about why the COVID-19 response needs international relations. So shortly, I'd like to say that Claire is assistant professor at the London School of Economics, and she does research on health, on global health and governance, and she has published quite a lot on this topic. Precisely the paper she's presenting today, it's a recent contribution of hers, a paper that she's co-authored with Sarah Davis, and that has been published in International Affairs. So Claire, as Martijn has just suggested, I will now give the floor to you so that you can present your research for about 30-40 minutes, and then we will open the floor for, I have some comments and suggestions for you. Hello, Claire, now I can see you. And then we will open the floor for questions and comments from the audience. So without further ado, Claire, the floor is yours. Thank you.
Thank you so much. Thank you, Andrea. Thank you, Martijn. Thank you to eBay for inviting me to present this paper to you today, and wherever you're joining from. I hope this will be of interest to your thinking and your conversations around COVID, and why we really need to encourage policymakers to engage with political thinking and international relations theories and practice in particular to really understand and push through a lot of the barriers we're seeing in the coronavirus outbreak. I'm going to share my screen with you now. But when we talk about what went wrong with the coronavirus outbreak, when we talk about how we are still here 8 months later and still, particularly across Europe with this second wave, which is emerging, I think we need to start by asking, well, how have we got here? When we started this thinking and this work that I did with Sarah Davis that you are talking about, we started by thinking, well, you have Trump coming out, and I know this is a pertinent slide given what's happening tomorrow. You have Trump coming out and saying this is completely unprecedented. Nobody saw this coming. Nobody saw the pandemic coming. And, that's why we're on such a back foot. And that's why so many people have died. It's because it was completely unexpected. And we think that that's not true. We think that, in fact, it was entirely expected and entirely predicted. If you look at a lot of the literature and a lot of the policy documents that have come out in the previous years, there have been multiple times when senior academics, senior policymakers, senior public health officials have sounded the alarm that this is coming. So last year, the Global Preparedness Monitoring Board, which is an amalgamation of actors from the World Health Organization and the World Bank and a few other key institutions globally, got together to assess, where we were at in terms of our preparedness for outbreaks. And they said that, this is going to happen. Right? We're going to have this very real threat of a highly lethal pandemic of a respiratory pathogen killing 50 to 80 million people and wiping out 5% of the world's economy. And they said basically this is coming and nobody is prepared. So I think this answer that this point that Trump and several politicians have made thus far, which is that we didn't see this coming, is quite fundamentally wrong. We even seen modeling looking at how much this was going to cost. And the tension that we're seeing across the world now, this tension between the economy and public health, was also well established that it was going to lead to considerable economic impact, and there were going to have to be harsh and tough decisions made around the how do we prioritize people's health compared to the economy, where that line is drawn. And this wasn't just in international organizations or in the global health community. We've even seen these conversations around the real risk of a pandemic coming in national security strategies. So as early as 2004, the US government had suggested that epidemics were coming and the pandemic could, pose a serious threat to American citizens, to the international community. In the UK, where I am, we had a fundamental policy, Health is Global, which first came out in 2008 and then was updated in 2011. And it clearly demonstrated this link between the politics and pandemics and indeed security, and how we had to focus on getting the UK and indeed the whole world ready for a pandemic, because any emerging pathogen in any part of the world could pose a risk to UK borders, was the mandate with the policy. So indeed we have seen this coming. And it's been an increasing area of policy analysis and policy development in the last 2 decades. And this is predicated on this understanding of prevent, detect, respond. And that if we want to be able to manage the risk posed by an emerging pathogen, of an epidemic, of indeed of a pandemic, we need to be able to figure out where it's happening, stop them happening, connect to them immediately, and then be able to respond to this. So we've seen growing policy at national, regional, and global levels being created, particularly in the post 9/11 era, and the move to kind of securitize lots of areas of public life. We've seen this increasing securitization and increasing policy importance put on this real security risk to economies and to populations posed by infectious diseases. And so, for example, for the prevent part of this, we've seen the world actively engaging in activities to try and investments to try and mitigate against some of the potential harms of outbreaks and trying to stop them. So how can we ensure that we've got community trust, so people tell doctors if they're feeling ill, for example, because that's the first root of it. How do you ensure that if an outbreak does happen, that it's reported up the chain quickly? How do you ensure that there's community trust to try and ensure that when outbreaks happen, communities will listen to their leaders and to the decision makers and change behaviours? How do we ensure that things we know cause potential pathogens, right? So, for example, animal husbandry practices where you have pigs and chickens and humans living in very close quarters, where you see these viruses jumping from one to another, and indeed entering human communities. How do we try and manage agriculture in a way to stop that happening? And so we've been seeing a lot of effort being put in all these areas, particularly around One Health in the last decade. So One Health being this animal-human interface, and trying to really push for an improved mechanism and improve public health capacities to be able to prevent outbreaks from starting in the first place. We've then seen increasing development of activities to be able to detect outbreaks. So we've seen widespread improvements to surveillance activities. And so making sure that there is ability for local diagnosis, there is laboratory capacity to be able to type the virus in your pathogen. There's a clear chain of command of what happens if you are in a doctor's surgery or a laboratory and you see something unusual, who do you have to report it to? And then how do you then start to manage these clusters to be able to detect outbreaks that are emerging? And then what happens next? Does everybody know that once you report it to your regional body, does that then go to the national? And then when does that report go to the World Health Organization, for example? We've also seen the development of non-governmental mechanisms for disease surveillance. So those that are not within state governance, but for example, the use of Google Trends, the use of clinical reporting and aggregate mapping of doctors sharing information to try and identify where clusters or new outbreaks might be emerging before they actually get picked up through government structures. And so we've also seen that these aren't just national activities. So we're seeing this increased involvement of these non-state actors, like I mentioned. But increasingly, we're also seeing greater international cooperation. So we're seeing some bilateral activity. So for example, the United States Department of Defense has a whole surveillance program where it has stations all around the world to try and identify outbreaks of epidemics before they become potentially epidemics. This is the same in the EU. There's a network for epidemiological surveillance within the EU to be able to try and detect across borders and share that information globally as soon as possible. And again, a similar activity in the African CDC has been established post the Ebola outbreak in West Africa. And we also see massive efforts being created to try and respond to the outbreak. So we see clear techniques being developed and policies being created around ensuring there's contact tracing, ensuring that there's surge capacity in your health system to be able to respond to a crisis. So there's public communication and people know who they need to communicate with and how they need to work with the media and with public bodies to try and share information. There's conversations going on around stockpiling vaccines and how we're going to distribute and access treatment, for example. And the WHO has also been doing a lot of work and a lot of building of trust, for example, to ensure that when they start making recommendations about travel advisories, for example, they are listening. And so there's a whole bunch of activities that have been going on for the last couple of decades. And most of these have been codified in the International Health Regulations, which is a key policy document and key piece of international law indeed, which was created by the World Health Organization in 2005 with the aim of trying to solidify some of the norms that have been emerging around prevention, detection and response. So how do we get all these policy ideas? How do we get all the knowledge that we have about how to to outbreaks and put it into one document so that all governments around the world can take this on board and then can start to ratify this document and implement all the best recommendations, so we're able to be in a place where when an outbreak occurs, everybody knows what to do, everyone knows how to respond, and we can globally cooperate to be able to minimize the potential risks in any one location. So this came out in 2005, and since 2005, we've seen a lot of governments trying to make efforts to implement international health regulations. Now, some have been more successful than others, but I would say across the board, we're seeing increasing implementation of these regulations and compliance with them. We see governments reporting outbreaks when they emerge. We see governments trying to build their surveillance capacity. We see governments trying to work in their prevention strategies with One Health units and veterinary activities. And so we've been seeing this increased compliance with governments. And indeed, these compliance with the international health regulations and how prepared governments are to be able to respond to an outbreak were measured only last year. So the Global Health Security Index is it's a group of academics who are based at Johns Hopkins, and they decided they were going to understand how ready any country and every country was in the world to be able to deal with a pandemic. And so they used a lot of the areas of the international health regulations and a few more beyond that to try and map, okay, where's ready for a pandemic, and conversely, and perhaps more importantly, as they argued, where isn't ready. So then the idea would be that to be able to then target global efforts to improve surveillance and improve detection capacity and laboratory capacity in the parts of the world which didn't have that capacity as yet, because the understanding is that we live in this global world where outbreaks can spread, so you need the whole world to be compliant with it. Now, interestingly enough, the Global Health Security Index, I'm sorry, this is really small slides when you look at this screen here. The Global Health Security Index listed the US as the #1 most prepared location globally to be able to respond to a pandemic. And indeed, the UK is listed second on this list, in that if an outbreak were to occur in these countries, we would be able to handle it. Now, that paints a very different picture to the latest data we've got on the coronavirus outbreak. And I'm sorry, these every time I try and update these slides, the numbers just skyrocket out. So they're slightly out of date. I think this was last week, maybe 10 days ago now. You're seeing this complete mismatch between the countries that were most prepared on paper and the countries that are now being the most affected. So obviously we're seeing, the greatest rates and the greatest incidence of COVID in the US compared to anywhere else. But then if you start to look at kind of case fatality ratios, for example, you can see that actually the UK has got, the highest death rate in Europe out of the science. And so this is really important. Why is there this mismatch between countries that on paper last year should have been the most able to respond to an outbreak and those which are actually not being able to respond to the outbreak? Now, in this paper, Sarah Davis and I argue that it's basically politics, right? And politics is what's driving why countries are doing well. It's nothing necessarily to do with your preparedness plans. It's nothing necessarily to do with how ready you are on paper. If at a point of crisis, these aren't implemented, and there are political delays or decision making which affects using the best public health approach that has been widely agreed on by the global community, then that's a real problem. And so this got us thinking about looking at politics, right? And if politics drives epidemics, which we argue it does, why do we not see the real risks to pandemic governance posed by politics in the policies that have been created to respond and manage outbreaks? So if we look at the key policies that we see at the global level, for example, the international health regulations I mentioned, the joint external evaluation, which is a mechanism designed by the World Health Organization to understand how ready countries are. The Global Health Security Agenda, which was an Obama administration effort to get countries working together to fulfill these requirements under the international health regulations and beyond. The Biological Weapons Convention, the WHO Research and Development Blueprint, which decides who's, how they're going to plan and develop vaccines and treatments. And then again at national levels in these national security strategies that I mentioned, there is no consideration in these documents around, well, what if politics gets in the way, right? How do we ensure that even if you have a, rogue leader in charge making really bad decisions, how do we somehow bring that political influence and that different varying nuance of administrations into how we create policy to respond to outbreaks, because clearly this is what's making a difference. You only have to look in the UK, for example. But we saw quite clearly early on in this outbreak that the UK government wasn't following the guidance of the World Health Organization, for example. And indeed, more alarmingly, it came out that we had done a pandemic simulation activity 3 years ago in 2016. And we had it come out with clear recommendations around where the weaknesses are in the British response to any pandemic. And it highlighted those weaknesses and those areas where capacity needs to be built up were in things such as access to PPE, access to beds in hospitals and ventilators. And so these had been well identified, but the Conservative government had decided not to follow through and carry on with these activities and fund, making sure we were ready for a pandemic, because they had decided to focus all their efforts on no-deal Brexit planning. So you can see how clear political agendas have driven how ready countries are to be able to respond. You see that very different politics occurring with leaders such as Jacinda Ardern, where you see clear leadership happening, a different sort of leadership happening. But again, what this allows us to see is the impact of politics on how outbreaks are governed. And the different political leaders, different political agendas, different political will have a real impact. So then we suggested that through thinking about the politics in this, we could actually use international relations analysis to be able to support decision making from here on in. And actually, we need to stop thinking about responding to outbreaks in purely epidemiological terms. We need to think about this more holistically and actually understand how, if you are, for example, at the World Health Organization, and you're trying to understand why some countries are following guidance, some countries aren't, the tools that are available and are well utilized in international relations can really support how you then go on to work with countries and encourage interrelations and cooperation between countries. And so we, in this paper, argue that there's 5 ways that our international relations can help COVID respond. So the first one of these is through comparative analysis. What's interesting about the coronavirus outbreak is that all countries in the world are confronted with exactly the same pathogen. So seeing how governments respond and seeing how the different countries respond allows us to understand how effective these are, for example. And you can see then the different outcomes of each of these responses. But it also allows us to see, whether you do follow World Health Organization advice, for example, how successful that is compared to not following it. And we argue that the decisions that are made around when countries decide to follow World Health Organization, when they decide to do it alone and chart their own courses, is largely based on political decision making and also indeed the political history of the country. Who's implementing the decision making behind the scenes? Why would decision makers listen to scientists or not? Or are they going to listen to public opinion or not? Or are they going to listen to the World Health Organization or the EU? And really understanding how each country is going to respond and how each country is going to work cooperatively or not is vital to then be able to target policies at a global level in a suitable way. So we need to understand why states make these decisions, right? Because we know that they lead to different outcomes. And if we can understand why governments make particular decisions, we can then try and target those decisions which aren't necessarily leading to the best public health approaches. Using IR can also tell us about the global governance of epidemics. So we know that governments don't make decisions and don't respond to outbreaks in a vacuum, but they're part of this much bigger multi-stakeholder landscape of global health governance. So we have governments, we have international organizations such as the World Health Organization, we have big NGOs such as Médecins Sans Frontières, Doctors Without Borders. We have a number of funding agencies and philanthropies such as the Gates Foundation and World. We have this whole landscape in which governments need to operate. And it's really important that we understand how governments cooperate within this and what's brought them together and what allows them to follow these global governance trends. And this also allows us to understand the role of the World Health Organization and its position within the broader global health landscape. If we think of the World Health Organization as a technical body, a technical organization providing guidance and best practice public health guidance, in theory, what you want is governments all around the world following that advice, because that is simply, with all the best evidence out there, the best decisions that could be made to protect people's health. But we haven't seen this happening. Indeed, in the UK, the Deputy Chief Medical Officer in March said, the clue's in the name with the World Health Organization, right? And she suggested the WHO policy was addressing countries all around the world in very different health infrastructures, and that actually the UK didn't need to follow WHO guidance because we have a very strong public health infrastructure. Now, that was a critical mistake in the way that the UK has handled the pandemic. But this understanding of when you're following WHO guidance or not is, again, vital to understand within the context of the global governance output. And this leads on to broader considerations around the role of the World Health Organization going forward. Now, like many UN institutions, the World Health Organization is far from perfect. There are a lot of tensions within the World Health Organization, such as the funding structure. That WHO only has control over about 20% of its budget, and the rest of the money that comes into the organization is ring-fenced by donors for particular projects that they want to fund. As a funder like the Gates Foundation, you can come in and say, I just want to fund malaria control. And you can put all the money into that. Now, that works for them because it allows them to demonstrate that they're hitting their objectives, but it means that WHO can't then shift money and or decide how it wants to spend money. So this tension between this technical versus normative. So the WHO in its mandate, in its constitution, is a technical body providing guidance. But it's also increasingly becoming this normative body which provides guidance and engagement between states and really mimicking best practice. This then means that it's constricted by the politics of member states. So it's the member state organization. Governments give it the power to make these normative commitments. Then it has to do so in a way which doesn't challenge the politics. So, for example, you don't see the WHO calling out its member states because it is a member state organization that's very aware of its politics. So even as we see the US leaving or potentially leaving, depending on who wins the election this week, we don't necessarily, we don't see the WHO calling them out and saying, how ridiculous it is because they recognize their positionality in its membership landscape. The WHO also has, creates these pieces of international law, like the international health regulations. But how do you get governments to abide by international law? Now, I know this is a widespread question across international relations. But for things like outbreaks, which are so transnational and affect everyone globally, how do you get governments to follow this guidance, whether through the legal structures or through this normative role the World Health Organization can play? We see this tension I mentioned between China and the US playing out at the World Health Organization. And how does WHO try and manage that, particularly with many more actors that are coming in to fill some of this space? I don't think it's simply about a balance of power argument between USA versus China, but we're seeing increasing role, for example, of Scandinavian states, of Germany, of Mexico, right? We're seeing other actors coming into the fold. So how can we then get WHO to claim more authority and more power in outbreaks to be able to push the best public health response and to get governments to listen to it? We saw this during SARS. So during SARS, the WHO had unprecedented power to be able to put travel recommendations out around how to mitigate the spread of the disease. But that hasn't happened in this outbreak because mainly governments aren't listening. So how can we use trust building, for example, trust building exercises and political engagement, which is much more likely to work, and to try and encourage greater normative cooperation with the World Health Organization and between states, rather than this sort of burying the head in the sand approach to political engagement that we see right now. And this is important It's important not just thinking back historically as to what's happened this year with the pandemic, but also thinking about what's to come with the pandemic. So, it's likely that we will have a vaccine in the coming months. What happens then, I think, is also going to be really fundamental for understanding the global governance of the response. So, as some of you may know, there's this COVAX scheme which has been implemented and highly championed by the World Health Organization to provide equitable distribution of vaccines so that every country around the world can get enough vaccine to be able to vaccinate 3% of their population, which the idea of being that would be your healthcare workers and your clinically vulnerable and old groups of your population. Now, whilst we're seeing governments around the world sign up to this, we're also seeing governments, or richer governments, also create their own bilateral contracts with pharmaceutical companies to be able to procure doses directly as well. And so I think there's going to come this real key point when we see actually what happens, and is global cooperation going to work in responding and in vaccine distribution, or are we going to see this retrenchment of the national? And I think the WHO has a really important role to play there. And I'm worried that their lack of normative power and of convening power risks a very unfortunate outcome for a lot of the world through this COVAX scheme. IR can also help us think through the financing and the international political economy of the outbreak. So we know, for example, the World Health Organization lacks money. And as I mentioned, through the way the WHO is financed, it means lacks money. But even if you think about the immediate response to the coronavirus pandemic, the WHO has not had the money to do it. So the Health Emergencies Programme of the World Health Organization is only 74% funded at the start of the outbreak, and that hasn't really increased. So it hasn't even got a full ability to be able to respond. So then what happened was the WHO launched this strategic fund for COVID response in February to try and get governments to contribute to be able to tackle the outbreak. But that only got about 49% funded of what they needed. So governments weren't paying into this fund when they needed to. And so the WHO was then caught in this difficult position where it simply didn't have the money to do everything it needed. So we saw the WHO launch this solidarity. So that was getting anyone in the public, you and me and everyone else, could donate, $1 or more to this solidarity fund to try and, get money into the organization to be able to respond to the outbreak. But this is highly unsustainable. And, this was all championed by the big concert they had online with Lady Gaga to try and raise money. But this isn't a sustainable way to finance outbreaks. And if you look a bit further in this, we've had tensions, for example, with the World Bank, who created a pandemic emergency financing facility in the wake of the Ebola outbreak, which has seemed to be a wide failure in that it wasn't able to pay out until May because of criteria that are required to be met before payment. There's concerns around actors like the Bill and Gates Foundation, which is obviously throwing a lot of money into responding to COVID, but very much in the vaccine and development side of things. And there's broader concerns around what role they're going to play in governance going forward. And then we see this tension between, in previous outbreaks, such as the Ebola outbreak, we've seen donor states giving money to those governments who are suffering from pandemics to be able to respond to it. But obviously that hasn't happened in the same way here in this outbreak, because those governments that you might expect to be able to fund pandemic response, UK, US, and Scandinavian countries, have been dealing with their own domestic crisis. So they've been trying to focus efforts and money there. And so the risk is you see broader inequalities come as a result of it. So the question will be then is, how do we try and mitigate this financial trouble? How do we work with new forms of co-financing? Because I think effectively we're going to have to engage the private sector again to be able to get more money to finance this. And these are all questions that the IR can help. IR can also help with questions around trust and of rights. So we know, for example, that one of the key problems we've seen in this outbreak has been this infodemic and this miscommunication, fake news. People know what they're supposed to be doing. And indeed, the public trust the health advice they're given. Do they trust the authority of the domestic government or international institution providing such advice? Now, you see this most starkly in the questions around face masks in the US and in other places, particularly in the US, and how partisan it became, the use of face masks. You see people like Bolsonaro talking about it's only a little flu, we don't need to worry about it. And if that's the message your government is giving, how does that then impact on public health and in public perception? And then the conversation we've been having in the UK around should we pursue a herd immunity strategy or not also becomes highly political, and it really is fundamentally linked to this question of trust. And are we making sure we trust in the institutions? And there's this balance between not really trusting the government, but also wanting this outbreak to be over. And so we see populations sort of falling and flipping between trusting and not trusting institutions. And finally, we suggest in this paper that we can use IR to understand kind of the gendered impact of the coronavirus outbreak. So, for example, we know that healthcare workers around the world, so about 70% of them are women. And so when you start to then think about who's performing all this labor, who's performing all this care to treat all these patients, it's women. And if you go into social care sectors and care homes, it's up to 90% of the labor force are women. And so we really need to understand that this is women who are responding and assuming all the labor that's involved in responding to a pandemic. But that's not the only gender effects we see in the outbreak. We know, for example, that distortion of health systems as a consequence of the prioritization of COVID patients means that women have got less access to sexual reproductive health services. We've seen stockouts, for example, of contraception globally. We've also seen a kind of demand side issue of women not wanting to go and access sexual reproductive health care, not wanting to access maternity care, because they don't want to go into hospitals or antenatal settings where they fear they might contract coronavirus. And so we've got this tension now, and it's really alarming concern that's coming out of multiple countries of increased rates of maternal mortality, for example, because women aren't going to all their antenatal checkups, and we're not being able to predict and prevent some of the poor health outcomes that can come through routine pregnancy. And then I'm sure you've also all seen the risks posed by gender-based violence across the world, and how we're seeing increasing stark rate of gender-based violence, and that's not a surprise. Anyone who knows, who knows about gender-based violence, we know it happens in the home. So what happens when you shut everyone in the home and make people worried about their jobs and their finances? It doesn't take a rocket scientist to see how we've got there. But we also need to think about, and this is something that the IR can make you sort of think this one step further, and feminist international political economy makes you wonder, well, it's not just about women being affected by the outbreak, but also in terms of, or infected by the outbreak, say as healthcare workers. If you look at the industries that are most affected by lockdown and by changes to activity because of public health interventions, things like accommodation, hospitality, education, retail. These are the job categories which can't happen at home, right? And they all were shut as a consequence of lockdown. What this meant was we've seen increasing job and financial insecurity disproportionately fall on women. And we're seeing this increasingly, right, through increased rates of unemployment for women as a consequence of this outbreak compared to men. And that's not just because of the sectors they work in. Obviously, that's important. It's also important to remember the micro effects of the kind of domestic load occurring within households, in dual parent households, around who's going to work, who's staying at work, and who's looking after children, for example. And that's partly due to kind of gendered norms, but also importantly due to gender pay gap, and recognizing that if you have a choice around who's going to go to work, you're going to send the one who earns the most. And so IR really allows us to unpack all of these direct and indirect effects of how we've got into this situation, and allows us to create this roadmap for analysis that is crucial to going forward with the coronavirus outbreak. And I just wanted to share this last slide, because indeed, when we did analysis of the Ebola outbreak in 2015 and 16, the rhetoric that comes up again and again is that the reason the Ebola outbreak was so stark was because of this perfect storm, that we had poor health infrastructure. We had people moving across borders. We were in a new place where countries weren't ready for the outbreak. We had poor capacity in the health system. People didn't trust governments. There were concerns around the private sector and mining rights. So, and again, in the UK, we're seeing questions around the private sector and the use of the public health care. And this crisis, this health crisis, soon became a much more wider societal humanitarian disaster. And when I look at this, I find it quite chilling, because actually, it's basically the same thing. Haven't really learnt or improved our mechanisms we use to respond to outbreaks in the last few years. We haven't learned from the Ebola outbreak, despite knowing all these issues. And so this is sort of our plea, which is that, if we know this is what happened, we know this happened in Ebola, it happened in Zika, and it's happening now in coronavirus, we really need to start to rethink the way we govern outbreaks, the way we prepare, detect, and respond to outbreaks. And we think that a useful way of doing this is making sure we don't hide from the politics, but instead we engage politics and international relations analysis in the way we approach and create policy to make it more realistic for the political world we live in. And I stop there, but I really welcome any questions.
Okay, Claire, thank you very much for your presentation. Certainly this is very timely and relevant, as I said at the very beginning, because it's a very interesting contribution to the debates we're having today on what existing theories and frameworks tells us about how states are responding to this health crisis. So my comments are based on your paper. I have 3-4 comments, questions, suggestions for you, and then I'll try to be brief so that we can have more questions and comments from the audience. So in the paper, you mainly explore the role of the WHO as an international organization, and then you present these very interesting practical examples of how IR can contribute to decision-making and technical coordination processes when responding to pandemics and health crises. So regarding these first aspects of your paper, you characterize the WHO as an organization of states. You certainly underscore the relevance of power and state capacities, and also the difficult roles the WHO has to orchestrate, as you say, these actors. And this seems to be the case to some extent since the creation of the WHO in the 1940s. Now, to some extent, this organization has been described as being quite particular when it comes to its structure. So it has been even referred to or characterized as a federal organization. And this has to do with the fact that the WHO has 6 regional offices, right? So there are these 6 regional offices within the WHO, which to some extent are quite separate from the organization, and they are run independently by elected regional directors. And in this sense, it's very particular the case of the Pan American Health Organization, which in fact predates the WHO. So my question is, okay, so this is an organization of states, but what role do regions and regionalization processes play in the day-to-day politics of the WHO, but also when it comes to crises and pandemics as the one we are facing today? I would say that regionalism can work as a meso level between the WHO and the states. So my question would be, do you think this enhances the role of the WHO, or are these organizations or this federal structure in fact a hindrance to the governance of the WHO and the governance of global health, right? And also related to the question of governance, as I was reading your paper last week, I ran into, there was this news in the newspaper where they explained how the WHO had recognized 15 cities across the globe that had managed to respond to the COVID crisis in a very efficient and effective manner. So cities, there was 15 cities like Bogota, Buenos Aires, and others, right? So what role could cities play within pandemics, within global health, right? Because in fact today, when we talk about migration, for example, cities are also portrayed as a relevant actor, right? When it comes to integration policies, etc. So going to the second dimension or aspect of your paper in terms of how IR can contribute to health decision making. Certainly, I do agree with you that IR is very useful, and I wonder whether we would need, in fact, more dialogue with comparative politics, right? Because when we, I mean, and this has been a debate starting in March, right? So how countries or why countries decide to cooperate, and even issues like the differences we have observed in the ways in which democracies versus authoritarian regimes have responded to the crisis. So it's clear that this distinction between the domestic and the international, to a certain extent, no longer stands. So borders are blurring. And this seems to be especially the case when we study transnational challenges, as it is the case of health, for example. And also, I enjoy very much reading your sections, the sections of your paper where you talk about the impact of pandemic on human rights, the impact of the pandemic on human rights and on gender. And I find this interesting because similar arguments have already been posed by people studying migration and how health is affecting the migration crisis in South America these days, for example. And you even mentioned in your presentation, right, the portrait of health crisis as security problems, right? And this was even the case during the Ebola epidemic, when the Security Council at the United Nations precisely adopted a resolution saying that this health crisis was a threat to international peace and security. So, in all, given that health is a transnational challenge, but given that pandemics and health crises have several sides and dimensions that involve different policy areas, is IR enough, or do we need the scientific community to find the means to engage in more dialogue between disciplines to face these certainly multidimensional transnational challenges that can also be treated or through different levels of governance? So I think I would leave it there. And would you like to respond to my comments before getting some questions? How would you prefer to do that?
Sorry, I pressed the wrong button.
It's okay.
I'd love to respond to them. Thank you so much for taking the time to read it and to think of these really important conversations and questions. I think the question about regions is really important. I think it's becoming increasingly important. So the WHO has always had a very difficult relationship with its regional offices and the structure, because often the regional offices have been challenging the norms that are happening at the global level. Some of them have, they have their own budget as well, so they're able to implement their own programs, but that also proves problematic when there's a misalignment between what's prioritized at regional and at global levels. We also see the tension that often the leadership in regional bodies is political appointments rather than people who are the best person for the job. We see quite a lot of ex-statesmen becoming heads of regional bodies, and that can also prove tense. And I think this is going to become even more problematic if the US does indeed leave the World Health Organization. And I say that because there was a really alarming article a couple of months ago basically saying that PAHO, so the Pan American Health Organization, the regional body for the World Health Organization in the Americas, is teetering on the brink of insolvency. It just doesn't have enough money to run its programs. And if the US leaves, it's basically going to go completely bust. And then what does the World Health Organization do? Does it cross-subsidize and cross-finance a regional body? And I think the feedback would probably, and certainly the conversations I've been aware of, have basically said, why would we finance the richest regional office in the world, right? Why would the African Regional Office or WHO headquarters, when they have such little money, put that money in? It seems counterintuitive. But I think that's really important, and I think it's going to have a massive effect on a lot of response to COVID and all the other work that happens. I mean, PAHO runs, the biggest dengue project globally, right? And what happens to everyone who gets dengue fever in Latin America in the next coming years? They're probably not going to have any care or provision as we see increasing activity happening around COVID. But I think also, as we see increasing, the more political answer is, as we see increasing retraction to nationalism and a lot of governments not wanting to take part in global effort and global corporations, that it might be a strategic activity by the WHO to strengthen those regional offices. Because you might see governments who don't want to work globally but would be happy to cooperate regionally. And we're seeing regional cooperation for health, occur across the world through the EU, through ASEAN. ASEAN has got a great regional cooperation for global health, and indeed for implementing the international health regulations. They've got their own ASEAN shared cooperation strategy for trying to ensure prevention and detection of outbreaks. And so you can see these kind of novel governance arrangements appear. And it might be that actually WHO has to push for those to be able to maintain its activity if WHO as a central global body doesn't work. However, some people suggest, you could get rid of the global level WHO and just have regional actors, but that then means you don't necessarily have that, oversight and trans-global oversight that you need in terms of outbreaks. And so it's in a really difficult position. The question about the cities is also really interesting. I haven't read the article you refer to, but we're seeing a lot of conversations going on, particularly colleagues at Georgetown are working on this, looking at the role of mayors, for example. How much power do mayors have in implementing responses to outbreaks? And and particularly when you see different approaches between mayors and between federal governments, which we're seeing again and again. And then how do you kind of match those things up? Whereas if a mayor is doing particularly well, that's against government guidance. How do you manage the power relations, the money, and indeed stopping things coming in? Because you might have a really good local strategy, but you can't put a border around your municipality or your town to stop things being introduced. And indeed, finance depends how much of that you have on your own. And then the question you asked about migration and security, I think, is so important, which is that, think about outbreaks, they're caused by migration in one way or other, right? They're all caused, the reason we have a pandemic is because people have moved from one place to another in the very basic sense of what migration is. And there's a lot of literature on migration and epidemics, and, the way that migrants get personified as the risky people in societies, and they're the ones bringing in the ill, bringing in ill health to an otherwise healthy population. And that's obviously been widely condemned for being inaccurate, and actually it's often those are the groups that are able to spread outbreaks in countries rather than import them, and that's mainly because of a lack of access to healthcare facilities, a lack of access to medication and to health that those people might not have rights to in different locations. So they're not the people who introduce it. It's not that kind of internal external dichotomy, but they are the ones who then spread disease. And so I think that any sensible policy would put them right at the center, and indeed we do see that in some places, not universally. But if you think about, for example, the migration crisis in Latin America that you mentioned. I mean, even thinking before COVID, you saw that the Venezuelan crisis led to considerable transmission of HIV across the continent, right? And considerable transmission of Zika across the continent in places that had got these things under control. And so you can just see that, like, there are these tensions that need to be built into policy. But at the time of outbreaks, and this is part of the policy, this is part of the problem, is at the time of when the pandemic emerges and you get this kind of crisis mode, where you just think about stopping the outbreak and no one thinks about the broader groups, the vulnerable groups, it's just about short-term security. This is the threat, let's stop it, rather than thinking, well, actually, what's the most sustainable way to stop this? What's the way we can stop this and also ensure rights of our populations and rights of migrant communities, and do it in a way which is inclusive? That never really becomes part of the conversation. Is that everything? I can't remember.
Oh, that's perfect. Yeah. So maybe this would be something to think about for coming pandemics, right? So it's not just a question of responding. I mean, it's a question of responding to the pandemic, but thinking in broader terms of the whole implications of the crisis.